Greetings, dear students. Today we are going to take a class on one of the very important topics in surgery, that is hernias. Especially I'll be talking more about inguinal hernias because that's one of the pathology which you will be coming across more often. And when you consider your exams and when you consider practicals or theory for that matter, anywhere you go, diagnosing hernias are very, very important. So when you talk about hernias, the definition of a hernia: protrusion of a viscous or a part of the viscous through the wall of the containing area. Especially when you have an abdomen and there is a defect in the abdomen, you have a swelling which is protruding through the abdomen. Especially when you have a paraumbilical hernia, it protrudes through the paraumbilical region, and the covering is usually the peritoneum. So when you have similar swellings arising in different parts of the body, especially in the inguinal region, it is called an inguinal hernia. When you have it in the femoral region, it is called a femoral hernia, or it's in the lumbar triangle, it's called a lumbar hernia, or you have it in between the xiphisternum and the umbilicus without any incision for that matter done earlier, it is called a ventral hernia, or in between the fibers of the linea alba with it, the preperitoneal pad of fat which protrudes out, it is called an epigastric hernia. So depending on the site and the pathology, hernias are varied and different. But for you, inguinal hernias are very, very important because you can get this as a practical case scenario, or you can get it as a problem based question in your theory, or part of it can be a short note, or for that matter it can present in a way which can be extrapolated into multiple choice question options. So it is important that you understand the fundamentals of hernia, and especially I will be talking to you about inguinal hernia. So when you consider inguinal hernia, an inguinal hernia is the protrusion of contents of the abdomen, especially the bowel or the omentum or the bladder for that matter sometimes, through the inguinal canal. So when you're talking about the inguinal canal, the anatomy of the inguinal canal is always very, very important. The inguinal canal always slides downwards and medially. So if you're going to put your pocket in the hands in the apron pocket, the direction in which your hands lie, that is the direction of the inguinal canal. So it is directed downwards and medially on both sides. So when you have the inguinal canal, it has an anterior wall, it has a posterior wall, it has a floor, and it has a roof. So when you consider these four structures, what are these four structures made of, especially when you consider the inguinal canal? Though the obliquity is present, the inguinal canal is always patent because of certain mechanisms in normal individuals which prevents inguinal herniation. So that I will talk to you later. But just considering the anatomy, when you talk about the anterior wall, you have the skin, the subcutaneous tissue, the scarpas and the campus fascia, and then you have the external oblique aponeurosis, and then you encounter the inguinal canal. So all these structures which I told you, they form the anterior wall of the inguinal canal. When you consider posterior wall of the inguinal canal, the posterior wall of the inguinal canal comprises two basic muscles which are very, very important, that is the internal oblique and transversus abdominis. And there is a fascia which is present in the posterior wall, that is called the fascia transversalis. So the posterior wall is made of internal oblique, transversus abdominis muscles and fascia transversalis. So these are the three structures which make the posterior wall. The roof of the inguinal canal has got a peculiarity that part of the posterior wall forms the roof of the inguinal canal, that is the conjoint tendon, the arching fibers of the conjoint tendon. So the conjoint tendon is made up of the fibers of the internal oblique and transversus abdominis. So the arching fibers of the conjoint tendon make up the roof of the inguinal canal. So three walls are now defined. One is anterior wall, posterior wall, and the roof. And the floor is made up of the inguinal ligament. The inguinal ligament is nothing but a reflected portion of the anterior wall of the inguinal canal. The external oblique aponeurosis comes anteriorly and it reflects down. That forms the inguinal canal and forms the floor. The lateral 2/3, it forms the floor, and the medial 1/3 to 1/3 is formed by the lacunar ligament. So the inguinal ligament in the lateral 2/3 forms the floor, and medial 1/3 is a lacunar ligament. So all the 4 walls are now defined. So considering the normal mechanism which prevents herniation is called a slit valve mechanism. So slit valve mechanism is where you have the floor and the roof coming, the posterior wall and the roof coming together, especially when the patient strains. That is, the internal oblique and transversus abdominis contract. When you have a contraction of the internal oblique and transversus abdominis, usually it happens that the conjoint tendon also is a part of the internal oblique and transversus abdominis. So both of them come together and shut the inguinal canal. So that maintains the integrity of the inguinal canal. That is called slit valve mechanism. So it's very, very important so that it prevents the inguinal herniation. The other one is, especially when you have the round ligament or the cord structures going around, you have the cremaster which winds around it. So the cremaster muscle, especially when it contracts, it comes and plugs the superficial inguinal ring. So superficial inguinal ring is a triangular slit in the external oblique aponeurosis. So it comes and plugs the superficial inguinal ring. That is called the ball valve mechanism. So whenever you have these structures, especially the slit valve mechanism which comes and plugs the ball valve mechanism which comes and plugs the cremaster, it is called the cremaster muscle which comes and plugs the superficial inguinal ring, it is called as a ball valve mechanism. And when you have the initial one which I told you, which is the sliding one, where the walls come and oppose together, that's the shutter mechanism. That's not the slit valve mechanism, that's a shutter mechanism where the posterior wall and the roof come together and oppose each other. The slit valve mechanism is the two parts of the split valves or the split fibers of the superficial inguinal ring come together and join together. That's called the slit valve mechanism. So the superficial fibers come and join together, especially of the external oblique, that's called slit valve. The cremaster comes and plugs the superficial inguinal ring, that's the ball valve. And the shutter mechanism is the posterior wall and the roof coming together and joining. That is called the shutter mechanism. So the three mechanisms prevent the normal herniation in a normal individual. So when you consider an inguinal hernia, usually the anatomy which is again to be considered is the Hasselbalch's triangle. The Hasselbalch's triangle has laterally you have the superficial epigastric artery, and medially you have the medial border of the rectus abdominis, and inferiorly of the inguinal ligament. So when you have the superficial epigastric artery, any hernia which comes lateral to that is called an indirect hernia, and any hernia which is coming medial to the epigastric artery is called the direct hernia. So Hasselbalch's triangle, any hernia through the Hasselbalch's triangle is a direct hernia, which comes lateral to that is an indirect hernia. So whenever you consider the contents come through the deep ring and come through the abdominal through the inguinal canal and comes throughout the superficial inguinal ring, and sometimes it might descend into the scrotum. So when you have a contents which comes and is confined to the superficial inguinal ring, it is called a bubonocele. A hernia which comes and descends partially into the scrotum is called an incomplete inguinal hernia, and a hernia which comes directly to the base of the scrotum is called a complete inguinal hernia. So depending on these positions of this inguinal sac, you can differentiate into a bubonocele, incomplete, and a complete hernia. Usually a direct hernia comes through the posterior wall. Most of the direct hernias come through the weakness in the posterior wall. Indirect hernia comes through the deep ring, traverses the canal. Either it might be in the canal, outside the canal, in the scrotum, especially partially or completely. So these are the differentiating features between a direct and an indirect hernia. But how do you clinically diagnose a direct hernia or an indirect hernia? Always remember, two cardinal features of hernia are impulse on cough and swelling. If you don't have any of these or one of these, it cannot be clinically called a hernia. A hernia is always a clinical diagnosis. The two cardinal features of any uncomplicated hernia are impulse on cough and reducibility. So these are the two, swelling and impulse on cough and reducibility are the two features which are very, very important, especially in a uncomplicated hernia. So when you consider these factors, what would you call a indirect hernia, or how do you clinically diagnose an indirect hernia? As it has been told, the deep ring, you have to occlude the deep ring, especially the fascia transversalis, and tell the patient to cough. If nothing is coming out into the inguinal canal or swelling is not coming into the inguinal canal, then it is an indirect hernia. That deep ring closure is called the ring occlusion test. So closure of the deep ring is called the ring occlusion test, and closure of the deep ring further can be confirmed by doing a finger invagination test, especially when you have a male patient. Put in your little finger through the scrotum into the superficial ring and come to the inguinal canal. So you're entering the inguinal canal with pronation, with supination like this, and you pronate it. So when you pronate, the posterior wall of the inguinal canal is always facing the pulp of your finger, and tell the patient to cough. And if you have an impulse at the pulp of your finger, it is a direct hernia. If you have an impulse at the tip of your finger, it is an indirect hernia. So an impulse at the pulp of your finger is a direct hernia. Impulse at the tip of your finger is an indirect hernia. This is ring finger invagination test. So ring occlusion test, finger invagination test. Associated with it, you have the Z-Man's technique, where you occlude the superficial ring, the deep ring, and the femoral ring is also blocked, especially when you have all these three fingers. The index finger, the middle finger, and the ring finger blocks each of this. And depending on the impulse where you feel, it can be differentiated to direct hernia, indirect hernia, and a femoral hernia. Femoral hernia always comes through the femoral ring, especially it is the medialmost compartment of the femoral sheath, and that descends down and comes down. So femoral hernia is usually seen in elderly individuals, especially females who got gynecoid pelvis and who are postmenopausal. And because the femoral ring is wider, you get femoral hernia in females, and whatever the contents usually come out is the omentum. Bowel rarely comes out, but sometimes the bowel will come out, it is strangulated or it will be obstructed. If the omentum comes out, it stays there for a long time, and sometimes it gets strangulated and the patient presents with pain, especially when you consider a femoral hernia. So indirect hernia would always come through the deep ring, traverse the canal, and come and stop at the superficial ring or come into the scrotum. A direct hernia always would come through the posterior wall. So how do you differentiate a direct hernia from indirect hernia? As I told you, deep ring occlusion test. If you don't get a swelling after occluding the deep ring initially by reducing the swelling when the patient is coughing, that is a indirect hernia. But though you're pressing the deep ring, but the swelling appears medial to the pressure, the area where you're pressed, then that is a direct hernia. So on deep ring occlusion test, if the swelling is not appearing, it is an indirect hernia. If the swelling is appearing medial to the finger where you have occluded, it is a direct hernia. So it's very, very important that you differentiate a direct hernia from an indirect hernia based on ring occlusion test, Z-Man technique, and finger invagination test. These are the basic three fundamental tests which will differentiate a direct hernia, indirect hernia, and especially Z-Man technique will tell you more about a femoral hernia also. So another characteristic feature of a femoral hernia is the area in which it presents. A femoral hernia is always, inguinal hernia is always present above and medial to the pubic tubercle. A femoral hernia is present below and lateral to the pubic tubercle. So it's very, very important how do you differentiate these two. One is, if you have a femoral hernia, always suspect femoral hernia in elderly postmenopausal females, and when you suspect inguinal hernia, especially indirect inguinal hernia, it is suspected in people who are very muscular, young aged individuals, and a direct hernia is seen in people who are elderly and who have weak musculature, or factors which contribute to hernia. Especially the factors which contribute to herniation in the inguinal herniation are smoking, or patients who are malnourished, or patients who have got chronic constipation, or patients with chronic cough, or patients who have got other forms of increased intra-abdominal pressure, especially patients with benign hyperplasia of the prostate where you have lower urinary tract symptoms. All these would contribute to herniation or formation of inguinal hernia. So before you try repairing an inguinal hernia or going for a treatment for an inguinal hernia, always treat the cause first. You treat the patient for a BPH if the patient has got a BPH, treat the patient for chronic constipation by finding out the cause of it, or treat the patient for a tell the patient to stop smoking if the patient is a chronic smoker, or a COPD that has to be treated first. So the cause should be treated before treating the hernia. So coming to the investigations which are required for a hernia, actually clinically speaking, hernia is only a clinical diagnosis and hardly you do any investigation which is required for that. And if you want to do an investigation, an ultrasound can be done to rule out any intra-abdominal masses, or a CT scan can be done to rule out any intra-abdominal masses. But otherwise, usually hernia doesn't require an investigation to confirm its diagnosis. Second thing which you can do for hernias, especially when you're considering treatment for these hernias, is you have to either talk to the patient and going for a minimally invasive approach or a operative approach which is time tested. So minimally invasive approach can be through the peritoneum. That is two broad classifications of minimally invasive approaches, Dept and TAP. That is total extraperitoneal approach, where you go in between the peritoneum and the anterior abdominal wall and put a mesh, and total abdominal approach, where you go into the abdomen and plug the deep ring and put a mesh there. So these are the two laparoscopic approaches. When you consider the approach which are operatively done, the most commonly done nowadays is Lichtenstein's tension-free hernia repair, where the posterior wall is strengthened by putting a mesh, especially in the posterior wall, and suturing that to the conjoint tendon above and the inguinal ligament below. That is called Lichtenstein's tension-free hernia repair. Why it is called tension-free? Because you are not opposing or bringing any muscles together by suturing. And these are done by non-absorbable sutures. Either it can be done with polypropylene sutures or other non-absorbable sutures which will hold the mesh in place. The other herniorrhaphy techniques, or where you don't use a mesh, are the Bassini's repair, where you oppose the posterior wall and the inguinal ligament by using sutures and tying it tight. That is called Bassini's repair. Modified Bassini's repair is you darn in between the inguinal ligament and the posterior wall. You keep on darning. That is called modified Bassini's repair. The other repair which is done for hernia is called the Scholdi's repair, where the fascia transversalis is cut and it is double breasted. The inferior flap is brought superiorly and the superior flap is brought inferiorly, so that this forms double layer. That is called double breasting or Scholdi's repair. So Raffi techniques are Bassini's repair, modified Bassini's repair, and Scholdi's technique. And plasty, especially when you're using a mesh, it is called hernioplasty, and it is called Lichtenstein's tension-free hernia repair. So it's very, very important. If you're asked an open technique, the most commonly done technique is a Lichtenstein tension-free hernia repair, other than the laparoscopic approaches. The laparoscopic approaches are usually very good when you have a bilateral hernia, where it will be less time consuming, less cumbersome, and usually patient can have a fast recovery. For that matter, unilateral hernias also can be approached laparoscopically. It all depends on the choice of the patient and how you approach the patient. So it's very, very important that whenever you have a hernia, you'll have to treat and you'll have to tell what are the consequences. Now talking about the complications of hernia. Hernia can get obstructed, hernia can get strangulated, or either it might be either of the two, or it might be irreducible. So if it's reducible hernia, it's an uncomplicated hernia. If it's an irreducible hernia, it's a complicated hernia, but patient doesn't have any symptoms. It is just a swelling which is present in the inguinal region, but patient is not bothered about that. Obstructed hernia is where the bowel has come out and the bowel lumen has got obstructed, and that will cause the contents to stay in the loop which is inside the inguinal canal, and the neck is the constricting area. So the bowel will keep on swelling with the contents, and you have toxic materials being released from the bowel into the third space, into the sac, and the patient will keep on becoming the septic, because the toxic contents will be coming to the peritoneal covering, that is the sac, which is going to get absorbed in the body. So obstruction is very, very important. It has to be dealt with immediately. And strangulation is a feature where the blood supply to the bowel which is come into the sac is gradually getting constricted because of venous congestion and edema. And because the blood supply is getting constricted, the area of the bowel which is in the sac and which is distal to the neck and which is in the inguinal canal, the skin overlying that changes its color. There will be signs of inflammation in the skin overlying that. Either the signs of inflammation will tell you that it's a strangulated hernia or it's an obstructed hernia. So if it is a strangulated hernia, you'll have all the signs of inflammation on the overlying skin. So the examiner might ask you, how do you differentiate obstructed hernia from a strangulated hernia? Your answer should be, the overlying skin will have signs of inflammation in a strangulated hernia. What are the signs of inflammation? There will be edema of the overlying skin, there will be redness on the overlying skin, there will be tenderness in the overlying skin. It is not seen in obstructed hernia, though the patient might present with pain, but it will be a swelling there, and the patient might present with signs of obstruction especially vomiting, constipation, pain in the overlying area. But in the strangulated hernia, along with that, it has gone to the next level where the bowel blood supply is getting obstructed, and hence patient will end up to be more toxic and more septic than an obstructed hernia. So it's very, very important that you diagnose all these things. Another complication which you can tell is incarceration. Incarceration is basically the large bowel being a part of the hernial contents, and the material which is inside the large bowel is inspissated feces. That is feces where the water content is got absorbed, and that is called an incarcerated hernia. So complications can be irreducibility, obstruction, strangulation, incarceration. So if you are asked about complications of an inguinal hernia, you'll have to unequivocally tell all these and justify why you're calling it a strangulated hernia when you have a swelling there and pain in the abdomen, when you have the same thing happening in an obstructed or irreducible hernia also. So you'll have to justify your diagnosis. So it's very, very important that you understand the hernia completely, and wholesome diagnosis is very, very important. So with this, I hope that you've understood the basics of hernia, the anatomical basis of the same thing, the clinical basis of the same thing, the complications, the treatment part of it, and how do you approach a patient who presents with hernia. Thank you very much.